Hi everyone, I'm Jannis from ETH in Zurich, and here I present our project POCOVID-Net, automatic detection of COVID-19 from a new lung ultrasound imaging dataset. And as you know, in the current pandemic, we have different testing methods for COVID. For example, direct tests like PCR, or indirect tests, imaging-based tests, which are oftentimes used to support the diagnosis, like CT or X-ray, chest X-ray in particular. And CT is even considered as a gold standard for COVID diagnosis in China, but all these methods suffer from some disadvantages. PCR can take several days to process, and CT exposes the patient to excessive radiation, whereas X-ray, for example, was shown to be less sensitive for detecting COVID. Ultrasound instead is a technique that is very cheap, it's non-invasive, there's no radiation involved, it's repeatable and easy to perform at patient bedside, it doesn't require any relocation of the patients, and it's available in almost all medical facilities. So it really paves the road toward a method that is actually globally applicable, because CT is something that's restricted to developed countries with only about 30,000 CT scanners available globally, and PCR is also something that you will not find in remote areas. So the question is how in these countries, in these remote regions, how can you detect a local outbreak by repurposing the current available testing methods that don't require any development of new technologies. So this is where we believe ultrasound comes in, where it has two roles. First, in basically triage situations where there's limited resources available, and second, in countries where there's generally low resources available. So this is why we believe it's promising to look into ultrasound when it comes to using AI imaging CNNs for automatically detecting COVID. And so nowadays there have been more than 100 publications and preprints that focus on using computer vision for automatic diagnosis from CT or X-ray data. But there's nothing on ultrasound, and this is the niche of our project. So looking into the literature, there's a lot of advocacy these days to assign a higher role for ultrasound in the current pandemic. And especially there have been comparisons to CT also in terms of timeline of the symptoms that are observed during the disease evolution. So GGOs are the most common patterns that are observed in CT, and there's this corresponding concept of B-lines, which is visible in ultrasound, and for other patterns, similar correspondences do exist. So we had to start and set up a data set because no clinical data set of lung ultrasound images was available to us. We assembled this dataset mostly from public resources. This means publications that report case studies of COVID-19 patients, but also case studies of bacterial pneumonia cases and healthy controls. And the second main source of our data was educational websites for medical doctors. So based on these sources, we assembled a dataset of more than 110 videos and 50 images, where in addition we also had some data being recorded from healthy controls by medical people in our team. We then pre-processed all this data to be digestible for CNNs, basically cropping and removing artifacts, and we ended up with a set of three classes of, as I said, COVID, bacterial pneumonia, and healthy controls, mostly taken from convex probes and very heterogeneous in terms of the used ultrasound machines. We're still continuously updating the dataset, and we are very much looking forward for everybody who's keen to help. So here we see the performance of the model obtained in a 5-fold cross-validation. We see that we obtain a 90% accuracy in this three-class classification. The sensitivity for COVID specifically was 93% and specificity 87%. We still see that we have a lot of false positives here, so 22% of the healthy patients are actually incorrectly classified as having COVID. It's rather the type of mistake you would like to have if you have to make a mistake. Still, we see there's a lot of room for improvement, and in general we see that bacterial pneumonia was fairly easy to distinguish from the other two classes. So here we look more into model explainability, especially the class activation maps, which is a technique that can highlight the most relevant patterns in an image that drove the classification process, basically. And we assess to some extent whether the model has an inherent ability to localize spatiotemporal biomarkers of pulmonary diseases. We also deployed the model on a website called POCOVID Screen. So there's a prototype available that you can use. You should obviously by no means use this model for diagnostic purposes, but we show a demo of the model there, where we at the moment just perform a very simple class prediction, but we are planning to update it in accordance with the class activation maps. We also deployed the model on a website called POCOVID-Screen, where we make a prototype available that you should by no means use for any diagnostic purposes, but you can see at the moment the class predictions alongside their probabilities, and we also plan to integrate the class activation maps there in the next weeks. So to conclude, basically, we believe the results are promising. We mostly with this work wanted to point out that lung ultrasound is extremely So to conclude, our main goal with this project was to point out that lung ultrasound is extremely underappreciated in the realm of AI for COVID imaging data, and we would like to see a shift in the machine learning community more looking into ultrasound and less on CT and X-ray to some extent. We believe that we've demonstrated that the results are promising. They are numerically comparable to CT and X-ray, while ultrasound again has many practical advantages. But we are aware that we haven't used clinical data in here, which is the definite required next step in order to bring the algorithm on the next level. And we ideally would like to compare the predictive power of ultrasound in a multi-modal study directly with CT and X-ray. So our current work focuses not only on frame-based classification, as we've seen here, but also on video-based classification that directly ingests the 3D structure of the data, and also on a validation of the class activation maps in a human in the loop study, and in addition also on model robustness and on confidence estimates. And with this, I would like to point to our remaining resources. We have all the data and code public on GitHub, and also our website is here, POCOVIDscreen.org, and I would like to thank you for your attention and for my great team.